Good afternoon. My name is Kwak from Seoul National University Children's Hospital. I'm a congenital and pediatric cardiac surgeon. So I'm going to present my opinion for these patients with 17 years old who already underwent pulmonary valve replacement due to probably tetralogy follow or pulmonary atresia. So he underwent his previous pulmonary valve replacement at the age of 10 with 25 millimeters pericardial valve. And now his valve deteriorated. This situation could be expected when we put the valve at the age of 10 for this patient. So this paper published 10 years ago, we investigated the midterm durability of the bioprosthetic valve in pulmonary position. Patient age was similar to this patient. The 5-year reoperation-free rate was nearly 50%, and without statistical difference, the Carpentier-Edwards pericardial valve shows more frequent reoperation rate for 5 years of the follow-up duration. And probably this 70-year-old boy's prosthetic valve will be like this, severe degenerative calcified change. Back to the patient information. From this information, I could guess that he had underwent transannual RVET widening for his original disease because 25 millimeter at 10 years means his RVET already showed the severe aneurysmal change at that time. He showed now the moderate degree of the pulmonary regurgitation and moderate degree of the pulmonary stenosis. This might be a cardiac MRI data. The degree of his right ventricle volume is certainly increased, but not that large. And RV systolic function seems to be preserved. At this point, we should focus on his age. Sorry for this, the weird talk, but we Korean have a very unique age counting system. So we count newborn's age as a 1. So if this patient's 17 years old, Korean age, he might be a 15 or 16 years old, and he can have a potential to grow more. If this 17-year-old is a biological age, means he has lived 17 years so far, he is almost adult and he's growing almost finished. So in terms of the valve size, this patient has a 25 millimeter valve now, but its orifice must be less than 25 millimeter, at most 22 or 23 millimeters. Less than 23 millimeters of pulmonary valve in the adolescent age, durability could be a problem. So we published our data about durability of the bioprosthetic valve according to the age and valve size in 2016. And we found that if the patient is in adult age, durability was very excellent, almost no valvular dysfunction after 10 or 12 and 14 years after the implantation. However, if the patient is on the adolescent age, between the 10 to 20, even though the valve is large enough for the patient, the valvular dysfunction occurred after 10 years. However, as I said to you, if the patient is adult, even the small valve is working very well like this after 10, 12, or 14 years after the surgical implantation. So how about this patient's right ventricle status? Information says the end diastolic dimension is around 130. It seems not that large for immediate pulmonary valve replacement. However, I suggest that we should consider the situation where the patient is placed. The patient has a pulmonary stenosis as well as pulmonary regurgitation. That means the patient's right ventricle could suffer from the hypertrophy because of the pulmonary stenosis, and this could interrupt the dilatation of right ventricular volume. This table is showing the change of the right ventricular volume in the patients who underwent redo pulmonary valve replacement in our center from the ongoing study with Dr. Lee and Dr. Eun Kim in Sejong General Hospital. As you can see, the first column, even after PVR, as the bioprosthetic valve deterioration is going on, the right ventricular volume dilated again from the 120 to 150. So, however, the volume is smaller than the first PVR RV volume, but some patients required in this situation second PVR because of the valvular dysfunction. Therefore, we need more information in addition to the volume status, such as the end diastolic pressure and patient functional status and size of the infundibulum through other studies like the exercise test and CT or catheterization study. How about the materials? We recently found out that the porcine valve is more durable in pulmonary position in the long term. Of course, we know the excellency of the percutaneous valve in pulmonary position and getting better recently. However, longer observation is required. You see the excellent outcome of the PPVI in this paper, but there is only 4 patients who are followed more than 10 years. So my opinion for these patients, if the patient's age is 17 years old with a wide infundibular area and he already grown up enough, CAS data shows a marginal or deteriorated ventricular function, I think it will be better to implant the Raj valve more than 27 and then consider percutaneous PVR later. If the patient is 15 or 16 years, CAS data shows a tolerable ventricular function, weight and regular follow with echocardiography and cardiac MRI, and then surgical PVR later with a large valve, and then consider percutaneous PVR later. If the patient is the 17 Korean years old with a CAS data shows a marginal or severely deteriorated ventricular function, PPVI should be considered for these patients until the patient's ventricular dysfunction recovers. Thank you very much.